All right. Well, I am very excited to chat with Dr. Eric Balcavage as we are going to talk about thyroid physiology. And really, I don't know how deep Dr. Eric's going to go, but again, I'm all for talking about the thyroid. And I've been reading his book, and obviously, we're not going to be able to cover everything in his book. That's why you need to go and get his book, The Thyroid Debacle. But let me go ahead and give Dr. Eric's background, and then again, we're just going to dive right in. So, Dr. Eric Balcavage is the owner and founder of Rejuvagen, functional medicine clinic in Chadsford, Pennsylvania. He is nationally recognized speaker and educator on various health related topics, including thyroid physiology, bile physiology, detoxification, oxidative stress, methylation, as well as chronic illness. So, Dr. Balcavage is a functional medicine practitioner and a licensed chiropractor in Pennsylvania. And he is the host of the Thyroid Answers podcast. So, the podcast focuses on answering the pressing questions those suffering with chronic hypothyroid symptoms can't get answered elsewhere. And you can also find his educational Thyroid Thursday videos on Instagram as well as YouTube. And Dr. Balcavage has made it his mission to change the way medicine looks at hypothyroidism, and he's also, I mentioned earlier, his book, the co author of the book, The Thyroid Debacle, and the book also co written by Dr. Kelly Halderman. And it addresses the problems with current allopathic and functional medicine approaches to hypothyroidism, as well as the solutions to restoring thyroid physiology. And Dr. Eric, thanks for joining us.
Hey, thanks for having me on, Eric.
All right. Well, let's before we talk about your book and thyroid physiology, what led you and Dr. Kelly to write the book in the first place? Because as you know, there's no shortage of thyroid books out there, but yours definitely takes a different perspective.
Yeah, I got into functional medicine really by accident. I had a family member who got diagnosed with hypothyroidism, fibroids, and anemia, and they were told they were going to need hysterectomy, iron supplementation, and thyroid medications for the rest of their life, and that's just the way it goes. And I was asked to help, and I said, "It's not what I do," right? So, but when your brother says, "Hey, I need your help," you start figuring it out. So I went back to my roots of chemistry. I was a medical technologist before I made the decision to go off to chiropractic school, um, and got into looking at the chemistry, realized what was going on there. Started doing my functional training with Datis Karazian and Apex, and that was a great footing. And I'm sure you did some of those courses early on because Datis was kind of the man early in the day. Um, and then as I started working in my chiropractic base and talking about what I was learning, I realized how many of my chiropractic clients, were on thyroid medication. I really didn't pay that much attention to it, I guess, early on. I was more focused on what I was doing chiropractically. And as I was talking to them, most of them felt maybe a little bit better, but a lot of them still had signs and symptoms. A lot of them still had weight issues, had most of the classic signs and symptoms. So I started talking about Hashimoto's because that was this big thing that we this is an immune issue. It's not just the gland just doesn't fail one day. There's an immune driven process. And so I started getting more and more into functional medicine. But as I was doing that, we kind of had this philosophy in functional medicine, at least from my teaching, that the immune system was out of control and that the immune system just started damaging the thyroid gland. And, our job was um, to look for some of those stressors and the triggers, but not that there was a lot of hope. This is an autoimmune condition. Your immune system's lost control. It's going to damage your thyroid gland. And then the other piece of it we started looking at is T4, T3, reverse T3, and these other values that weren't traditionally being looked at in medicine, and making those decisions like, okay, maybe this is the thyroid gland makes both T4 and T3, so maybe we should be doing a little bit different job. Maybe we should be recommending T3 as well. And these silly medical doctors aren't aware that T4 is not converting to T3 well, and it's deactivating reverse T3, and having that and kind of changing the treatment based on that kind of thought process. The challenge I had the longer I went into this was I really struggled with the idea that the immune system just lost control and just woke up one day and decided it was just going to destroy the thyroid gland for no apparent reason. And that didn't sound good, like good sense, like good logic. I mean, why would the immune system just start attacking attacking our own tissues? And I thought there had to be something else going on. I was talking to a friend of mine, like this, it doesn't seem quite right that the immune system would do this, right? And I never really liked the term autoimmune condition. And it's an immune-driven condition, but I don't like the idea that the body just willy-nilly attacks ourselves. And so a friend of mine, Dr. Ben Lynch, who said we were preparing for a ShyCon conference, and he sent me a paper on the cell danger response. And he said, you need to read this. And when I read that paper on the cell danger response, I was like, oh, we operate in two modes. We're either in low stress, homeostatic regulation, or we're in a different state, which is allostatic regulation, which is an excessive stress response. And so I said, oh, this makes a lot of sense. And Dr. Navio kind of showed how, depending on the situation, we use micronutrients for one pathway, but in other situations, we may use micronutrients for a different pathway. And our physiology adapts to our environment, to the stressors, to what's going on. And I thought, man, maybe that is really what's going on here. The cells change their physiology, and the immune system changes its physiology based on what's going on in the body. And I thought maybe what we were seeing was more of an adaptive change versus this system out of control. Because if your immune system's out of control, that doesn't sound like you're ever going to recover. But if it's an adaptive physiology, then it would make sense that we just find out what it is adapting to. So that I got into really deep into looking into the literature, looking into papers, looking into the research. And the more and more I looked at it, it's my philosophy in general that a lot of what we see with thyroid physiology is an adaptive response to some type of excessive stress response. And if we can identify what those stressors are, reduce them, remove them, we can support the recovery of the physiology. And in many situations, we see improved T4 to T3 conversion. We see reduced immune damage to the thyroid gland, and we can see a thyroid gland recover in time. And many of my clients need less thyroid medication. The medication they take converts better, and a whole bunch of them in time don't need it at all.
Makes sense. So you're not saying that people with Hashimoto's and even non-autoimmune thyroid conditions don't need thyroid hormone, but most doctors are neglecting the physiology. So maybe some of these people don't need to take thyroid hormone replacement. Others might not need to take as much thyroid hormone as they're currently taking.
Yeah, I think in the allopathic model, the focus has always been on TSH and free T4. So what an allopathic physician, early on, we'd say these silly allopathic doctors and endocrinologists, they're only running two tests. They're not running thyroid antibodies. They don't know that this is an immune driven process. And I don't think that's the case. I think most of them realize that it's an immune driven problem. I mean, we pretty much know it's either iodine deficiency issue or it's an immune driven problem, right? And if you're in an area where there's sufficient iodine either in the environment or in our or repleted in our food sources, it's probably not an iodine deficiency. Um, so that leaves immune, and there, depending on what you read, it's thought to be 95% of the cases of thyroid, especially hypothyroidism, are immune driven. I would argue that whether there's antibodies or not, almost all of them are immune driven, because when you look at the immune system of people who have glandular hypothyroidism going on and negative antibodies, if you look at their T cell panels, they're Th1 dominant, which is going to result in lower antibody production typically anyway. So it's still an immune driven process. I think the challenge in functional medicine to some degree is that at least I was taught, or I think what I was taught, was that the antibodies are like little Pac-Man eating away the thyroid gland, TPO and thyroglobulin just gobble it up. And the literature shows that thyroglobulin doesn't create any damage to the thyroid gland, and TPO antibodies create very little. So if they're not creating much damage, what's causing the damage? It's the immune cells that are getting to the thyroid gland and creating the damage. And in that situation, they're T cells that are creating a lot of damage. But if you're Th1 dominant, you may not see it. So I think for the most part, what we're seeing is an immune-driven process. I think the allopathic world knows that, but they're coming at it from a point like, we're not going to suppress the immune system. We know the thyroid gland is going to get damaged. There's going to be a point where it can't make enough anymore. And we've got a simple solution. We just give them more T4. The thyroid gland makes primarily T4. So we'll just give it what it can't make, and the patient should be good. And the indicator that we're going to use that shows that we've reached euthyroidism or normalized the thyroid physiology is just a TSH within a preset range. If I give somebody enough T4 to bring the TSH into range, everything is right in the world. And unfortunately, that doesn't work for a whole bunch of people. And for a big part of that is that for the listener, T4 is the kind of the pre-hormone. It does have some functionality, but most of the functionality in thyroid world comes from T4 being converted to T3 inside your cells and tissues, and then T3 binding to receptors, and that's what's turning on your metabolism. So we can make the assumption that if the thyroid gland's not working and I just give the T4, it's going to convert to T3, but that doesn't happen. We can measure what it converts into, T3 and free T3 or reverse T3, but in allopathic world, they typically don't measure those things. So what you don't see, you can't manage. And so if you don't measure it, you can't manage it, you don't see it, the problem doesn't exist. But when we take a broader look at the panels, we can see that model in a lot of patients that are taking T4 only medication, their conversion of T4 to T3 is not very good. And that's probably why they're still symptomatic, is that they're taking more thyroid T4 than they need. That's impacting the conversion factor, but it also misses out on one other key piece. The assumption is that thyroid physiology is regulated by just how much thyroid hormone the gland makes, but that's not true. All the cells and tissues of your body have the ability to regulate how much thyroid hormone gets into the cell and how much T3 gets to the receptor. So cells have individual control. And the analogy I typically use is just if you have kids, Eric, do you have kids?
I have two daughters.
Has there ever been a time where you told them to go to their room and clean it up and they didn't do it?
Definitely.
Yeah. So just because we put T4 into the bloodstream doesn't mean that those cells and tissues are going to convert it into T3, which is going to stimulate the metabolism and upregulate the physiology. So I think there was a challenge in that model that it just assumed that was going to happen. And in functional medicine, I think we're aware of that it doesn't happen. Matter of fact, when you start to really look at the panels, the more T4 you start to give somebody, and this happens sometimes in that allopathic model, when somebody says, I'm still tired, I still don't feel good, and their TSH is maybe 2, a physician might say, well, let's just drive it lower. I'll give you more, and that must make it work. But if you actually look at a fuller panel and look at the T4 and the T3 and the free T3 and maybe the reverse T3, you're going to see that as T4 goes up, there's a point where T3 conversion often goes down. And that's a big reason why a lot of people struggle with chronic hypothyroid symptoms, even though their TSH is either normal or even maybe in the low end of the normal range, or even lab low.
So does it all come down to addressing that cell danger response? Because I'm sure you've heard and learned that like about 60% of that conversion takes place in the liver of T4, T3, and then some of it takes place in the gut, and then there's other factors. So do these all tie into the cell danger response, or would you say it's separate where people need to do other things to optimize their liver health, their gut health, their adrenal health, but at the same time also look into factors, stressors that relate to the cell danger response?
Well, I think the first part of it is some of the things we were taught about where T3 was made. The literature today is showing that those things aren't correct. So I was taught the same thing, that 60% of the T3 was made at the liver by deiodinase 1. And doesn't appear to be true based on the current literature. About what some of the current literature shows is that the thyroid any given day, the average person is generating about 30 micrograms of T3. About 5 micrograms, maybe to 10, depending on the individual person, is coming from the thyroid gland. Another 5 probably coming from the liver, another 5 coming from the kidneys, and then the rest of the T3 is coming from the peripheral tissues that can convert T4 to T3. The vast majority of T3 that's made in the body is not deiodinase 1 driven at the liver. It's by deiodinase 2 conversion in all the tissues that have deiodinase 2. So a cell brings T4 into the cell. It's got this enzyme called deiodinase 2 that converts T4 to T3. That T3 then goes to the receptors, gets used, then it pops back off the receptors, goes back out into the bloodstream, and contributes to the circulating level of T3 that we see on a lab report. And so I think that we have to keep that in mind, that it's some of the stuff we learned isn't actually correct, and based on the most current science. And do I think it's important that we address the cell danger response? I think it's critical that we address the cell danger response, because it's my opinion, based on everything I've seen and read over the years, that we assume that it's just about how much T4 or T3 is in the bloodstream, but really the individual cells and tissues have the ability to control what happens at that cell, at that tissue. If I'm a cell that's in low stress mode, I'm in manufacturing mode. I want to bring glucose in. I want to bring thyroid hormone in. I want to bring as much nutrition into that cell so I can make protein. I can make peptides into proteins. I can make hormones. I can generate hair. I can generate skin. I can burn tons of energy so I can feel and function awesome. Manufacturing mode. And I need lots of T3 active inside the cell to do that. That high concentration of T3 also helps contribute to turning off the immune inflammatory process. But if I'm a cell and I'm perceiving danger or a threat, whether it's an organism, a toxin, hypoxia, whatever the threat is, what Navio and other people who talk about the different aspects of the danger response within the cell, what a cell is typically going to do when it senses danger is slow down the manufacturing process and ramp up the cell defense. And one of the mechanisms that's used to do or to regulate almost every step of the cell danger response is the amount of T3 in the cell. So cells under stress, cells in danger, cells that are hypoxic are going to decrease the conversion of T4 to T3 inside the cell. And it sounds like it's a bad thing, right? It's going to slow down the metabolism, but actually it's a protective response. And so we're going to see that if somebody's got excessive cell stress going on, the thing that's causing that reduced conversion of T4 to T3 isn't oftentimes an inability to convert T4 to T3. It's not reverse T3 blocking receptors, but it's the cell defense mechanisms in place that are saying, hey, we're just going to downregulate the metabolism. And if we want to get into why that might be really important, we can get into it. But for most, I guess for simple standpoint, for the listener, you think about your cells and tissues just like people. If I'm in low stress mode, I'm eating, I'm sleeping, I'm having sex, I'm pooping, I'm doing all these great things. But if I'm perceiving danger, you can make me the best meal in the world. I'm not eating it, or I'm not digesting it well. I'm not doing wash. I'm not going to have sex. If I'm fighting for my life, I'm not going to go take a nap. I'm not going to have sex. I'm going to be in defense mode. And so our cells are like us.
Yeah. So what's interesting, so when you say stressor, some people might just think of emotional stressor, but you mentioned hypoxia. And then so I'm sure there might be some people saying, well, I'm probably not dealing with hypoxia, but how common is hypoxia? And can you talk a little bit more about that? And, I know on other episodes and, in your book, talk about things like mouth breathing, which a lot of people do. So I guess, yeah. Well, why don't we stick with that, and then we could talk about other factors when it comes to the cell danger response.
So to run the cell, it runs most efficiently when we've got oxygen, and we've got these little engines inside the cells that are called mitochondria. And the mitochondria can burn fuel, food energy, glucose, break down proteins and convert that into energy, or can burn fats. So we take food energy, and we convert that food energy into cellular energy. And we all learned about the mitochondria in 7th grade science class, and we learned about the Krebs cycle, which nobody loved because you had to memorize this thing. But essentially what that thing was doing was taking a glucose molecule and turning that thing into 36 ATP, which is your energy currency. And then we can use that ATP to do a whole bunch of chemistry reactions in the cell that make us feel and function good. Thyroid hormone plays a critical role in that. But to run that mitochondria efficiently, you need oxygen. And oxygen is a key piece. So if somebody has decreased oxygen getting into a cell, the cell now becomes more anaerobically without oxygen. It runs more in an anaerobic state, which essentially turns down the mitochondrial function, and we become less efficient at getting cellular energy from our food. So if a cell is in a low oxygen state, the mitochondria is unregulated. We're not going to make as much energy. We're not going to, and what does that feel like to us? We may not poop as well. We may be more tired. We may be more fatigued. We may feel more dehydrated. We may feel chronic thirst. There's a whole bunch of things that we may experience, more pain, more muscle tension and spasms as a result of not making cellular energy. So getting oxygen to the cells becomes critically important. Now, there's a number of things that can inhibit getting oxygen to the cells. One of the most common things that I think happens is people don't breathe well. And so we could say, well, I breathe a lot. Doesn't that mean I have a lot of oxygen in my system? But it's not that simple. When we breathe out, we blow off carbon dioxide and we bring in oxygen. So everybody thinks about, hey, as long as I breathe in a lot of oxygen, I should have enough oxygen. But this goes to the same thing that we were talking about with T4. It's not important how much oxygen's in the bloodstream as it is how much oxygen gets to the tissue. And so if I'm a red blood cell, I'm grabbing the oxygen that's coming from the lungs of what you just breathed in. And now I'm going around the body in the blood, and I'm going to give up oxygen to the tissue so they can run and function, let's say, optimally. But what allows that red blood cell to give up the oxygen? It's not just going to give it up. The only reason that red blood cells gives up the oxygen is because there's more of what we call carbon dioxide in the bloodstream. So if there's less carbon dioxide, that red blood cell doesn't want to give up the oxygen. It likes that carbon dioxide. I mean, it likes the oxygen, so it's not going to give it up. So if somebody is mouth breathing a lot, they're oftentimes blowing off too much carbon dioxide, which means there's less carbon dioxide in the body, less carbon dioxide in the bloodstream. They're breathing in plenty of oxygen. If you look at their oxygen saturation on a medical test, it may show 99% oxygen saturated. That sounds great because the red cells are saturated with oxygen, but that oxygen is only helpful when the red blood cells give it up. And they're only going to give it up if there's more carbon dioxide. So somebody who's mouth breathing a lot is going to have a tendency to be more hypoxic. Somebody who's mouth breathing, especially at night, is going to be more hypoxic. And just mouth breathing a lot through the day, blowing off too much carbon dioxide, or mouth breathing at night is going to contribute to a down regulation of your cell physiology and an upregulation of the immune inflammatory response. So that becomes a huge issue. How big of a deal is it? I mean, diagnosis of sleep apnea is exploding. And so everybody's wearing these fighter pilot masks to go to sleep anymore. And if you're wearing one of those things, if you've got cavities, if you've got gum disease, if you've got disrupted sleep, there's a good chance, especially if you go to bed with some stuffiness or congestion, there's a good chance you're opening your mouth at night to mouth breathe, and that's going to create some hypoxia. The other driver potentially of hypoxia is we have carbon dioxide that's in the bloodstream, and that carbon dioxide plays an important role. But if there's a lot of acidosis in the body can pull carbon dioxide out of the bloodstream to deal with the acidity in the body, and that too can drop carbon dioxide and and trigger this hypoxic state. Because remember, without the carbon dioxide, the red blood cells don't give up the oxygen.
So if someone has normal oxygen saturation, that doesn't rule out hypoxia. If someone has low, let's say they do a comprehensive metabolic panel and they have low carbon dioxide, they probably have hypoxia. If someone has normal carbon dioxide levels, I assume that doesn't rule out hypoxia.
No, it doesn't rule it out, because there could be other factors that prevent transfer. Now, I think the big thing that we say is, what is a normal oxygen saturation, right? So somebody might say 99% is normal oxygen saturation, and anything under, 90, let's say 93% is problematic. Well, I don't think 99% oxygen saturation. So if you have your little monitor and you put it on your finger and it shows 99%, I don't think that's healthy. I think that's a good indication that you may not be doing a great job transferring oxygen to the tissues. I like to see my patients somewhere in the 95, 96%, because that tells me that that's an indicator that they're probably transferring oxygen to the tissues a bit better. Now, somebody had 99%, they feel and function awesome, everything looks great. Hey, it's probably fine. But if I have somebody with chronic health issues and tiredness and fatigue, and they have weight gain and they have under conversion of T4 to T3, and they have 99% oxygen saturation, to me, it's a problem. As far as the carbon dioxide, I look at, oftentimes I assume that if I look at the blood panel and carbon dioxide's within the reference range, and I typically look at a reference range, maybe 25 to 28, based on some of the literature, as an appropriate carbon dioxide range. The lab reference range could be much lower. I think down to 20 is the lab reference range, and I don't think that's appropriate. But I'll also do calculations with sodium, potassium, carbon dioxide, to look and see if from a calculation standpoint, does it look like we have an imbalance.
And then anemia can also be a factor, which is why I'm sure you run a CBC, or one of the reasons why you'll do a complete blood count on everybody.
Oh, yeah, absolutely. So if somebody's got an anemia pattern, then they have less red blood cells typically to carry oxygen around the body. That too can be a potential problem. So uh, the broader the panel that we can run, the more important. Um, and anemia in itself is a whole nother can of worms, because what we tell most people is they have iron deficiency. And I think the vast majority of people don't have iron deficiency anemia. The vast majority of people likely have anemia of chronic inflammation. And in many times, I think we're treating that inappropriately, because we assume that if iron's low and ferritin is towards the lower end, that's iron deficiency. And I don't think it is in a lot of cases.
Talking more about blood tests, so you mentioned reverse T3 earlier. Is that something you recommend across the board? Would you say everybody should get reverse T3? At least those with, I'll say this, with hyperthyroidism, I stopped measuring reverse T3 because everybody has elevated reverse T3 and hyperthyroidism, and it really doesn't, in my opinion, add value. But, and again, feel free to give your opinion with that. But as far as like those with low thyroid or subclinical hypothyroidism, is that something you recommend for everyone?
I like looking at it for a couple of reasons, but not the reason that the vast majority of functional medicine practitioners like to look at it. I think, and I said this early on too, because it was what I was taught. So T4 is this primary hormone that's made by the thyroid gland, and then it gets to the cell, and the cell has what these enzymes, we call them deiodinase enzymes, that can either activate T4 to T3 or deactivate T4 to something called reverse T3. And that's cell driven. So the cell gets to determine, am I letting T4 in and converting to T3, or do I want to keep my metabolism lower and I'm going to deactivate T4 to reverse T3? So when I'm looking at a thyroid panel, and I never look at a thyroid panel by itself, because a thyroid panel without context of somebody's signs, their symptoms, the rest of the panel doesn't really tell me much. So I want to look at the thyroid panel with at least one tissue marker. But at the beginning, I look at a really comprehensive panel, which I'm sure you do too. But what's the insignificance of it? There's some in our space that say reverse T3 is the reason people have tiredness, have fatigue when they're on T4 medication, is that reverse T3, T4 gets converted to reverse T3 inside the cell. That reverse T3 goes to the nucleus and binds to receptors at the nucleus, maybe the mitochondria, and blocks T3 action. The problem with that, it sounds good. People say it's a mirror image of T3. A, it's not a mirror image of T3. And two, I haven't seen much in the way of, or any true scientific data that reverse T3 blocks T3 from functioning at any level of significance. And it just doesn't, I just haven't seen it. Now, if somebody says they have, I'm all open to it. I like the idea that it does it, but I don't think that's what happens. So when I look at reverse T3, what I'm looking at reverse T3 to see is a couple things. If I have a patient that's not on any medication, but they have signs and symptoms of hypothyroidism, and their TSH is normal, their T4 is normal, or free T4 is normal, whichever one somebody's looking at. I look at both. I want to see, what are their cells and tissues favoring? Are they favoring the conversion of T4 to T3? Or are they favoring the conversion of T4 to reverse T3? And if reverse T3 is higher and T3 is lower, then we can start to make some assumptions that, hey, maybe the reason somebody has hypothyroid signs and symptoms is because the cells aren't converting T4 to T3 the way we want them to. They're deactivating it. So then I know that I need to go looking for what's driving that under conversion or over deactivation. I go look at, what does the rest of my panel tell me? Are there markers of inflammation here that may be driving that process? What's the person's story tell me? Is there trauma? Is there emotional stress? Is there a hypoxia? Is there injury? Is there dysbiosis? Is there infection? Do they have sleep disruption? I start looking for the reason why. I just don't think that the reverse T3 is the problem. I think the reverse T3 is an indication that there's some cell defense potentially going on. If they had a, let's say there's still a normal, what somebody might call a lab normal TSH, and reverse T3, let's say, is low. Some people think reverse T3 should be non-existent, should be really, really low. I don't think that's the case either. But if T4 is low and reverse T3 is low and T3 is low, I know that we've got a person who's not making sufficient thyroid hormone. Okay, the gland's not working. Therefore, there's not enough T4 to convert to T3. There's not enough T4 to convert to reverse T3. And regardless of what my antibodies are or TSH is at that moment, we've got a gland problem going on. There's not enough hormone being generated. And so then again, I'll go back to my labs, health history, health timeline, and say, is there inflammatory mechanisms going on here that would cause the thyroid gland to be downregulated? And if I have inflammation is going to oftentimes going to increase the conversion of T4 to T3 at the hypothalamus, pituitary, at least early on. And so it can actually suppress TSH, even though I might need some more thyroid hormone in the system. So I'll use it for that, from that perspective. The third reason I want to take a look at reverse T3 is if I have somebody who's on thyroid medication, T4, and their doctor's happy that they're converting T4, they're getting enough T4 because their TSH is normal. I want to, and they're, especially if they're still tired, fatigued, and have all the symptoms, we know TSH can easily, or T4 can easily lower TSH levels really pretty quickly. The receptors in the brain are about 10-fold more sensitive than most of the peripheral tissues. So you can normalize the brain much faster. Plus, if you have this inflammatory response going on, that can make it normalize faster. But then at the cell level, what's happening? If they have high reverse T3, low T3, then I'm probably getting an indication that we still have this inflammatory mechanism going on. We need to go identify what that is. And two, they may be actually taking more thyroid hormone than they need, especially if they're struggling with some hyperthyroid type symptoms, brain fog, insomnia, irritability, things like that. So that's where I might work with them and say, hey, listen, I think the dose is too strong. Again, I haven't seen enough clear evidence that says that reverse T3 blocks anything from happening. If we wanted to block anything, we would blame deiodinase 3, which is the enzyme that deactivates it. So that's kind of the blocking effect. So that's how I use it. I think the better way to assess what's going on at the cell level is not just to look at reverse T3, because there can be things like reduced liver function that may cause reverse T3 the levels to rise. But if we just look at the free T3 to free T4 ratio, if that ratio is low, the cells aren't converting T4 to T3 appropriately. And there's probably some type of cell stress, cell danger mechanism going on. If the free T3 to free T4 ratio is elevated, then we probably have a state where the cells are starving for thyroid hormone. There's not enough T4 in the system. They need to make more T3, and they're willing to do that. And that's where you'll see the free T3 to free T4 ratio is high, above what we might call the optimal range of 0.31 to 0.34. So in a situation where reverse T3, somebody may say it's elevated, maybe. But really what I want to know is it elevated because I've just got too much T4 in the system, or is it elevated because I have some other inflammatory process going on? And that's where we can look at the free T3 to free T4 ratio along with that reverse T3 and say, hey, look, if this was just too much, or if it was on its own too much medication, we should be able to back that down, and then we should be able to see a better conversion occur. If there's inflammatory mechanisms going on, we're probably, doesn't matter if we back it down, we probably aren't going to see as good a conversion too early, too soon, until we start identifying what's creating that inflammatory mechanism and the down regulation of conversion.
So I have a few follow-up questions. If you could give, so you don't want reverse T3 too high, but as you said, you don't want it non-existent. You don't want it too low. So if you could say what what your healthy or optimal range of reverse T3 would be, and then also I think you mentioned the optimal range of free T3 to free T4 ratio, but if you could say that again, and then also you mentioned you test T4, the total T4, as well as the free T4. And I imagine you do the same for T3, the total T3, total T3, free T3. So I guess the optimal ranges for those. And then why do you test both total and free hormones?
All right. So the first question was, what do I use as a range? And it's important to know there's lab reference range, and then there's what some people call a functional range. And one of the things is, where do we get these ranges at? Because it seems like a lot of practitioners have their own range, right? So this is some people may say it should be less than 9 or less than 10 or whatever. For me, when I'm looking at the functional range, I'm more of a research geek. So I'm pulling up papers, kind of looking at stuff and saying, okay, where are we finding numbers here? And I kind of have stayed with somewhere in that 9 to 18 range is where we might want to see it. But every lab value has to have context. So if you said to me, hey, Eric, my reverse T3 is 15, that's optimal, right? Well, I don't know. What's your TSH? What's your total T4? What's your free T4? What's your reverse T? What's your total T3? What's your free T3? What's the ratios of these? I don't know if that's good. Is it good? Well, if your total T4 and your free T4 is low and your T3 is low, but your reverse T3 is 15, that's probably still inappropriate, right? Because you don't have much thyroid hormone, and you're still favoring the deactivation and not the conversion. Does that make sense?
Yes.
So even though I might use a reference range of 9 to 18, that is just like a starting point. I have to interpret the rest of the labs to see, is that appropriate? If I have a reverse T3, if somebody had a reverse T3 of 15 and lower values of T4 and T3, is that important? What do I make of that? Well, I'm also going to go look at the rest of the labs and say, okay, do I have any markers of tissue hypothyroidism going on? Do I have elevated lipids? Do I have elevated triglycerides, elevated VLDL? Do I have glucose resistance going on? If I have tissue markers of hypothyroidism going on, and I have a reverse T3 at 15 and I have lower levels of T4 and T3, I think that reverse T3, regardless of whether it's in a functional range, is still potentially problematic.
Yeah, makes
And
a
I
lot
think
of sense.
And I think that's sometimes the challenge. Even in functional medicine, we give allopathic medicine a hard time for saying, oh, they just look at an H or an L outside the lab reference range, and we have a better reference range. But just because our value is within the reference range doesn't mean it's appropriate. A lab value could be totally within the normal optimal range and be inappropriate, right? It could be appropriate. If you feel and function good, and you don't have much in the way of inflammation, and your TSH is 1.2, somebody might say that's the optimal. Okay. But if you have inflammation, you're tired and fatigued, you have all the signs and symptoms, and your TSH is 1.2, is that appropriate? Or is the inflammation suppressing TSH and that's causing my T4 and T3 to be low? So TSH is still normal at 1.2, but my T4 is low, my T3 is low, reverse T3 is low. So we have to interpret it. We can't just say, oh, because it's in an optimal range, it's okay. Does that make sense?
Yeah, it does. Thank
As
you.
far as the ratio of free T3 to free T4, this is a little tricky because the units of free T3 and free T4 are different when you get them on your lab report. So I think you can go to Weatherby, Dr. Weatherby's got a website. Do you know what that is off the top of your head? I can't think of
I
it,
don't.
but he's got a website and he's got calculators on there, and you can go to his calculator and you can put in right off your lab report and put in a calculation, and it'll tell you if it's in the ratio range. What I do is I just convert everything to similar units, picomoles per liter, and divide free T3 by free T4. And you can, if you look at your lab report, you can say, how do I convert picograms per milliliter to picomoles per liter? And the calculator will convert it for you. But if you convert things to picomoles per milliliter, then you divide free T3 by free T4, and that ratio, based on the literature, the optimal ratio looks like 0.31 to 0.34. If that ratio is under 0.31, the cells and tissues aren't doing a great job converting T4 to T3. And that's where we have to say, we have to go find out what's causing that reduced conversion. Is it low calories? Is it hypoxia? Is it organisms? Is it toxins? Is it emotional stress? Is it all of those things, like a combination of those things, which oftentimes it is? And if the ratio is above 0.34, then we might have a situation where even though maybe TSH is normal, there's still not enough T4 in the system to convert to T3, because those cells in a low T4 in a low T3 state are going to, if there's no cell stress response going on and they're in a homeostatic state, they're going to take as much of that T4 and convert it to T3 as quickly as possible, because T3, a certain level of T3 is a biologic priority.
And then getting back to the thyroid hormone, so you always test total and total and free hormones. Uh, and some, again, I have a habit of mainly testing the free hormone. So, what's the significance? Is it because if someone has maybe, like, I know you talk about in your book about the carrier proteins and thyroid binding globulins. So, if there's like a discrepancy with the free hormone and a total, maybe we're looking at a problem with the carrier proteins.
Yeah. So for the listener, in the body, we make hormones, but we don't want those hormones all being free, because they would get either deactivated, metabolized, or utilized right away. And we wouldn't want that, right? So hormones are made, sex hormones, thyroid hormones, other hormones, and cortisol, and they're then bound to what we call a transport molecule or a transport protein. They call it a binding globulin. It's like an Uber, right? And it just transports it around the body. And then when there's a cell or tissue type that needs some of that hormone becomes free of the Uber or free of the binding globulin. Now it's able to get into a cell or tissue. And so why might it be important to look at both total and free, even though a lot of physicians have gone to just looking at free because they're like, hey, free hormone is the only thing that matters. So we'll just take a look at free. But it does make a difference. If I have low free hormone because I'm not making much thyroid hormone, then maybe I need more I got to figure out why I'm not making as much. If I have low free hormone, but I have plenty of total, then I have to ask, why is it not getting out of the Uber? Why is it not coming off the binding globulin? Is it a pH issue? Is it a hypoxia issue? Is it some other hormone that I'm taking is jacking up hormone binding globulins? We need to find that answer, because more hormone, if you put more hormone into a system, the tendency is for the binding globulins to go up to manage it. But something is resulting in less hormone becoming free, and we need to figure that piece out. And so I want to look at both. If somebody's got low free, I want to know if it's because they just aren't making it, they have low total, or that it's a binding globulin issue, and then I want to address it appropriately. If they have high free hormone, I also want to know, is that hormone elevated because they don't have much, they're not generating much, so there's not much on the binding globulins, or maybe something is suppressing the binding globulins, causing a lot of excessive free hormone that's either being used or metabolized too quickly.
All right. Well, thank you. Thanks for that thorough explanation. I want to definitely circle back to the cell danger response, and before we wrap this up, but besides, when it comes to inflammation, I think you look at more than just CRP and sedimentation rate. You look at, like, I think it was, I heard elsewhere, like seven inflammatory markers.
So I think when we look at labs, there's a bunch of things we can take a look at from an inflammatory standpoint. That would be on a general blood chemistry panel. Uh, CRP, and there's high sensitivity CRP, there's regular CRP. Homocysteine could be considered inflammatory or molecule of oxidative stress. We could look at fibrinogen as a possible marker of inflammation of oxidative stress. We can look at elevated ferritin levels, and that's a whole nother can of worms. I think the vast majority of people believe that ferritin levels should be somewhere in the 60, 80, 90 range. I think that's absolutely insane. I think a ferritin level above, I don't like, I start getting concerned when I see a ferritin level over 25. But definitely, if you have a ferritin level over 40 or 50, that's an indication that there's potential inflammation and oxidative stress. And again, it needs to be interpreted. And so for the person who says, but I have low ferritin, I'm anemic. Well, hold on. If your serum iron is low and your ferritin is low and you're anemic, maybe you do have an iron deficiency, but we can run a test. It's called a soluble transferrin receptor to find out if the cells are starving for iron or not. But that's a whole nother conversation. But I don't think the vast majority of people are. But ferritin could be a marker of inflammation. We can look at bilirubin. And again, we have to take into consideration, is the bilirubin low because they're anemic, or is the bilirubin low because they're using bilirubin as an antioxidant because there's inflammation and oxidative stress going on? We can look at your elevations of uric acid. I'm probably missing something. We can look at alkaline phosphatase, elevated levels. And so just on a general chemistry panel, we can also look at elevations of 125 vitamin D and low 25 vitamin D. I mean, how many people today are being blasted with vitamin D, probably inappropriately, because they have a low 25 vitamin D when that's not really the activated form. The activated form is the 125. So if they have an elevated 125 vitamin D, that's another good indication that they probably have some type of chronic immune inflammatory process going on.
Yeah, well, we'll definitely need to get you back to talk more about the ferritin, because that honestly was a surprise to me. Talk as far as, like, you like to see it 25 or less, and then also talk about the 125 hydroxy. We don't really have time to dive into that, but when I went through my master's in nutrition, I don't know if you're familiar with Dr. Alan Gaby. He wrote a big book on, forgot the name of it, a big nutritional textbook. And when going through my master's, they were talking about how you don't want to look at 125 hydroxy because it's frequently elevated due to, I think they were saying, like, a compensation related to, like, the parathyroid glands. And just, again, this was now 10 years ago that I went through, or longer than that. So maybe the science has changed, but and then I know with Dr. Lynch, like, when I you mentioned Shaikan. I know he's a big advocate of testing for 125 hydroxy vitamin D. So definitely there are differences in opinion when it comes to testing for that.
I think we think of the traditional role of vitamin D and 125 vitamin D and 125 vitamin D with calcium regulation in the parathyroid gland. But we know way more than that now. And I'd say, real simply, without getting too heavy into it, if we think about vitamin D, and this is maybe, I think you think about it this way, right? There's very little food except for cold water fish that has any high level of vitamin D, right? So where do we get most of our vitamin D? We get it from sun exposure. Now, cold water fish have a decent amount of it. And so I guess if you believe in that, there's an intelligence in the universe, that might make sense, right? In the areas where we have plenty of sunshine most of the year, um, there's very little food that has any appreciable amount of vitamin D in it. Most of the vitamin D comes from sun exposure, and in areas where maybe there's less sun exposure, there's a lot more cold water fish where we can consume those things. But I don't think we're designed to be taking copious amounts of vitamin D as a supplement or orally. I know it's big pushed well; it's a $4 billion industry, but it's just my opinion. The other thing we don't really know too much about vitamin D is we only measure one component of it. We don't measure vitamin D. We measure 25 vitamin D. We don't measure what happens to 25 vitamin D. Is it being deactivated 24, 25 vitamin D? Is it just going into the fat cells? And that's a whole nother discussion and how that works and what I think is going on. Is it being over converted to 125 vitamin D? And then when you do have elevated 125 vitamin D, is there an inhibitory suppression of vitamin D to 25 vitamin D conversion at the liver? And some of the literature seems to show that that's the case. It's a feedback loop that turns it down. So I think we've taken vitamin D and taken one number that we can measure pretty easily and decided that if it's low, we just keep giving more, even in people that were giving 5,000, 10,000 IUs per day orally, they still wind up with low vitamin D. So I don't think we assess it right. I don't think we really look at the chemistry of what's going on. And I would make an argument that it is early on, it maybe make somebody feel better, but I think long term, it's potentially problematic.
All right. Well, thanks for sharing that. Definitely going to dive more into the research and maybe have more of a conversation on this in the future. But I can't have you leave without talking about some other things that
Mhm.
you mentioned in the book about addressing that cell danger response. Like, just obviously, a lot of it is the foundations. But if you could just spend the next few minutes talking about what else people could do. You mentioned the hypoxia and like breathing better. Obviously, people know about diet, but you haven't mentioned anything about diet. And I know you're not a fan of like one specific diet, that it's all about eating whole, healthy foods. But I'll let you take over and talk more about that.
Yeah, from a dietary, I think there's foundational principles, and Dr. Kelly and I talk about them in the book. I had a couple of colleagues that read the book and said, "Hey, where's all your supplement protocols?" And I'm like, "They're not in there because I don't know. I don't have a protocol for everybody. I don't. I think that's problematic. And I think even though it's not sexy, the things that create the health issues are these foundational pieces. There's, for the vast majority of us, better nutrition would go a long way to making us healthier, right? Whole food based diet. I think one of the problems we've had in this industry is that we've circled the wagons and shot in. So you and I both know that if you're eat one diet and you're not feeling well and you change to another healthy whole food diet, you're probably going to feel different. And so is there a benefit to doing a carnivore diet for a short period of time that you might feel better? Sure, because you're going to change your gut biome. It's going to create some change in symptoms. Is a vegan diet or vegetarian diet potentially going to create some change in signs and symptoms? Probably. But I don't think we should be arguing about which whole food diet is the holy grail. I think what we should be doing is saying, hey, primarily 80+% of the time, try and concentrate what you eat on healthy whole food, in season if possible, foods. Eat as close to the way it came out of nature as possible and limit the amount of processed food. If most people did that, they would probably start to improve their health and their well-being. And I see it every day as we start to make those changes with clients. I think respiration is critically important. And this is from a guy who's got a deviated septum and should have had surgery a long time ago. But breathing is critically important. And then we're designed to do most of the breath work through our nose. And a lot of us, because of chronic inflammation and a number of other factors, we do a lot too much mouth breathing, and excessive mouth breathing creates this hypoxic state. And just changing your breathing can change your health. Going back to the food, how we eat is becoming really important. Not only should you eat healthy food, but you have to take the time to chew it and help digest it well. You see a lot of people who are eating on the run and eating healthy food, but not sitting down to eat it, not putting themselves in a situation where they can actually digest it well, and then they still have problems. So I think sleep's critically important as well. I think I'm guilty of this. I went for years, wearing a badge of honor that, hey, 4 hours of sleep is all I need. I'll sleep when I'm dead. I'll do all this other stuff. And what it does is it creates created chronic inflammation, Hashimoto's, insulin resistance, and all kinds of stuff, because I was just 4 hours of sleep a night, plus running businesses, plus training, plus everything else I was doing. It breaks you down. That was part of my cell stress response. So I think that's important. Definitely, we hinted about emotional stress. What goes on between the 6 inches of your ears makes a huge difference as to whether you're going to get well, you're going to be stressed or not stressed. We all have stress in our life, and you're never going to escape it, whether it's physical, chemical, emotional, microbial. But what we say within our mind, consciously or subconsciously, plays a huge role in how we heal and recover. Far too many people take in too much negative or focus on the problem and not the solution. And I think that drives a lot of angst in the system, a lot of stress response in the system. So that's hugely important. So diet, nutrition, sleep. We talked about respiration, physical activity and exercise. And I think that's critically important too. I know some people don't like to do it, but you got to move your body. You have to do some physical strength training. You got to do some level of cardiovascular training. Slow fitness, I think, works really well for a lot of people. You want some, not excessive. If you're going to do a lot of excessive training, you got to also balance that recovery time. If you're not balancing the recovery time and you're doing excessive training, that's going to be a problem. You can say, well, I exercise, I have a healthy lifestyle. Well, the healthy lifestyle is if you train and recover. If you train and train and train and train and don't allow for recovery, you're going to have chronic health issues. I'm a perfect example of that. Drove myself into doing that. And so we talked about emotional, we talked about microbes, the organisms, they're everywhere. But if they overgrow in us, then that can potentially be a problem. And then we've got our environment with the toxins and things we're exposed to every day. You're never going to eliminate those things completely, but the best we can do to have a low tox life, that means there's less stress on the system. So I think I got most of them.
Yeah, I think you did. You hit a lot of them, most of the foundations, if not all of them. So great. Thanks for sharing that. And where can people find out more about you, Dr. Eric? If you can remind them again about your book, and then feel free to share your website and anything else that you'd like to let them know about.
Sure. So the book is called The Thyroid Debacle. So it's available on Amazon or Barnes and Nobles or wherever you get your books. So check that out. Um, I have a podcast called the Thyroid Answers Podcast. It's available on almost all platforms. You'll be a guest on that sometime in the future here. We got an interview scheduled. Um, I was never much of a social media person, but I got convinced to do some Instagram posts. So now that's primarily where I put out some content and information on Instagram. And one of the things I like to do is I do my Thyroid Thursdays, where I'm trying to educate. I know sometimes the people go on Instagram, they want like, here's the 3 simple tips. But really what I'm trying to do with those Thyroid Thursdays is help somebody understand maybe the free T3 to free T4 ratio, why that's important, and why it's maybe less valid if you're taking T3, that you can't really use that ratio necessarily to indicate what's going on. But I want to educate people, because at the end of the day, getting well is not based on how many supplements you can take. I find far too many people are over supplementing. Um, Getting well and staying well is about understanding a little bit more about your overall chemistry, and then doing a really good job raising your level of fitness in all these things that we call fitness factors: your diet, your nutrition, your exercise, your mindset, your habits, your behaviors. If you can raise your level of health in those categories, you're going to be healthy. I mean, but that's not the stuff that's sexy.
Well said. I will make sure to include those links in the show notes. And it's always a pleasure chatting with the fellow Dr. Eric.
Hmm.
Thanks for being here and talking about thyroid physiology and the blood test. Again, we'll definitely have to have you on again in the future and look forward to being on your podcast. But again, thank you so much, Dr. Eric.
Thanks for having me. I appreciate it.